First, we're going to hear from Sara Siegel, who is Global and UK Head of Healthcare at Deloitte, for very valuable insights. Thank you so much for joining us.
So the tough thing about being the fourth speaker is that I have to work extra hard to hold your attention, but I promise I will seek to do so. The good thing about being the fourth speaker is that I get to comment on the presentations that went before me. So I think I might start there. First of all, maths. I seem to have printed my notes on my son's maths homework, so I hope he's getting on okay in school today. But the second point I wanted to link to your presentation, Dominic, was the point about risk and the story that you told from your experiences at Skin Analytics. We had a very similar experience. My team worked with NHS Lothian up in Scotland to create a very simple AI tool which would help with the referral to triage process. It would read primary care letters and figure out what to do with them. Those letters had been kind of sitting in a queue for hours, days, or even sometimes a week or more, and before a clinician would get to them. And so people wouldn't know, should this be in the 2-week cancer wait, et cetera. We had the exact same experience where we did a very open book system. We built up an algorithm to read them, to triage them, and then we had clinicians check them. And then we tried to figure out, when the clinicians agreed, disagreed. And we had this very interesting conversation, which was, it had a confidence interval. So sometimes, and you guys will know this, a GP will write a letter and it will just say, like, please see Mr. X, he has pain. And there's just not a lot of information that a secondary care clinician can  use. Sometimes you'll get paragraphs and test results and you'll know exactly what to do. So those short letters had a low confidence interval. We triaged them accordingly. But what we found was that our baseline was that the AI was getting it right like 86% of the time. And people were saying, well, that's not 100%, which is true. But when we went back and did analysis of the triage that humans were doing, and were they getting it in the right place, it was, I won't tell the number, but it was lower. It was much lower. So again, we have to just remember where we're starting from. Where we're starting from is not a great place. Where we're starting from is taking a lot of risk into the system. But the sort of twist that I'll put on that story is, I think one of the challenges we have to adoption of innovation is we have to make sure that our clinicians are on side. And when we talk about AI, and especially generative AI, in my travels, I see that clinical workforce, doctors, nurses, pharmacists, are nervous about these technologies because they're scared that they're gonna take their jobs. And I've actually heard this language today, replacing GPs, replacing doctors. And I think the framing of this is really, really important. And what we found up in Edinburgh is that once we had clinicians in the lead and the medical director there was very much the champion for this program, they're so grateful because they didn't have time to read these letters. They could still look at the low confidence interval letters and call the GP, ask for more information, and then they had more time freed up to care for patients. So I think there's a lot in that, but I think it's a really good thing just to think about where we're starting from and keeping in mind the clinical workforce. So despite the accent, I have spent 20 years here in the UK working with the NHS, so don't let that fool you. But in my global role, I do get to travel the world and work with lots of different health systems, so I will seek to bring some of that to what I say here today as well. So the first question was, overcoming challenges, to adoption here in the UK. Why is it so hard? So hilariously, our research arm, the Center for Health Solutions, came out with a blog yesterday, which had 4 answers to this question, which are not the 5 things that I put on my screen. But it's a very good blog, and actually I posted it in my LinkedIn feed yesterday if people want to read it. I'll share theirs briefly first, and then I'll go through mine. So they talked about obtaining the right skills and talent, which has been mentioned this morning. They talked about defining or designing new funding and business models, which has also been discussed. They talked about innovative approaches to innovation. I really liked what Dominic was saying about the whole London approach. And they also talked about improving digitization and data governance. And I think those are 4 really, really good ones. Taking it back to some simpler challenges, I had these. Number 1, the NHS is so big. When we look at countries that we hold up as innovators in healthcare, they tend to be smaller. So, I've put 3 flags on the screen, Singapore, Israel, Estonia. Estonia had this e-health card. Patients had all of their own data for years. Singapore, Wes Streeting traveled there very famously to see all the innovations that they've been successfully implementing. Israel, startup nation, we have a global partnership with Sheba Medical Center in Tel Aviv. They have been able to incubate and commercialize innovations to the tune of billions of pounds of new value. It's absolutely incredible. Yesterday, I was on the phone with another small nation, although influenced by China, the Hong Kong Health Authority. They've had a single integrated care record for their 46 hospitals, which cover Hong Kong, since the year 2000. That's 24 years of full longitudinal integrated patient data and a care record. And they're looking at that and saying, what should we do with it? Should we be looking at things like what the UK is doing in terms of our Future Health UK Biobank? Is this data which is going to be useful for research, for population health, et cetera, et cetera? So we have competition from abroad. If I challenge myself and say, can big countries be innovative? Obviously, they can. But if I try to think of examples, there's a lot of money behind them. The one example I can come up with is, where I was born in the US, under Obama, when the Affordable Care Act came in, we saw a wave of digitization, the likes, and the speed at which no other country has seen. And the simple reason for that was that the government said, you're not going to get paid unless you can submit your invoices via these electronic systems and that they're all auditable. And that is a real driver for innovation. So, the first challenge is the NHS is so big, covering a population of 50, 60 million people, and because it's so decentralized, which was also discussed this morning, asking at that scale for scale innovation is a real challenge. The second challenge, and I think this is what's different to innovation in health, Edward, to innovation in other sectors, is clinicians. They don't exist in retail or financial services or entertainment or other sectors of the economy. And there's a lot of clinician power, and we can argue the toss over whether that's a good thing or a bad thing, but it's a thing, and we have to accept it. So, innovation in healthcare is different because we need clinicians not to be blockers, we need them to be the leaders. Any innovation has to come with and from clinicians. And that's why the rhetoric around Gen AI is so concerning to me, because when I look at what our practice is doing on generative AI, and we have use cases and proof of concepts being developed across the whole value chain of healthcare, I would say 90% of the use cases are aimed at making a clinician's life easier. But when I speak to clinicians out in the service, they're sure AI is coming to take their jobs. And there's just this huge dissonance. And I think that's a really big challenge that we have to get over. Point 3, there's not a hard line from the center. So in the NHS, I remember when I first moved here, I was like, this is so great. We'll put this new contract in place and it will just roll out to the whole country. And that's obviously not the case. There's not a hard line from the center. One of our speakers this morning said that he would centralize things more, and that would be a dream. It's not the way it works right now. So we really have to work in this soft power environment, in this very decentralized environment. The fourth one I put, and this might not be the right acronym, but NIMBY, which stands for Not in My Backyard. What I've seen around the NHS is that if it's not invented here, it's probably not a good idea. And I see people inventing pretty much the same thing 20, 50, 100 miles from each other. And I get that in some cases there can be competitive reasons for this. I think we should be using that competition to our advantage and not to create silos. I also, by the way, see this absolutely around the world. And I reflect on this a lot because I look at my colleagues around Deloitte who say work in financial services or even in our sister industry in life sciences. And they're working seamlessly in a global way. The organizations in those sectors of society are really global. But when we look at our sector of society, we're very much in country. The NHS is focused on the populations they serve in England. If I look at Kaiser in California or Cornwall in Michigan, we're all just looking in and down. So everyone is, can be connected, and people do collaborate, and the scientific community is great at this. But in terms of innovation and practice in the system, we don't have those natural connections, and we do have that competitiveness. Number 5, there have been few burning platforms. I will get to COVID in a second because that was a burning platform, which was obviously a very scary and terrible time, but good did come of it. But burning platforms are a great opportunity for innovation. And I remember Martin Elliott, who used to be the medical director at Great Ormond Street, used to run this conference, which was all about crisis and innovation. And he would bring these amazing innovators from across society who had come from war zones and other really challenging situations. And they would just talk about all of the good, all of the innovations that they had developed because they had to. And so I think we need to take advantage of difficult times when we have them. So obviously we have these 5 challenges, or 9, or 12, depending on whose definition you want to accept, and we need to overcome them. So the NHS is big. We need to break it down. And so I think that's why working in the conurbations that we have now, as Dominic was speaking about London and Manchester, and the way that we've structured things in the ICB setup, this is what we need to do. But then the challenge is we need to scale up. So I guarantee you that a good idea in London is also a good idea in the West Midlands. And we need to sort of break down those boundaries. There is a lot of clinician power. Let's use it to our advantage. I find in the programs that we work on, they all need to be clinician-driven, and not my clinicians. I can bring clinicians to collaborate, but the clinicians who are working in the trusts, in the client setting. There's not a hard line from the center. Let's start with some easy wins. Yes, there are things that the local NHS wants to innovate on its own, procure on its own. There are some things where they would just say, like, what is the best employment lawyer for me? Like, there are some panels they would take down from the center. And in terms of the not in my backyard, the competitive thing, I say let's make it commercial, let's make it collaborative. One of my favorite projects I ever did was with a region of this country that I won't name. We were working with primary care, and they were concerned that adoption of generic prescribing was low. How do we fix this? How do we get generic prescribing up? We're spending too much. These are all biosimilars. There's no need to be prescribing branded drugs in a lot of these cases. All we did was publish the data by GP practice and share it with the GPs. And then generic prescribing went up because they all saw where they were on the bell curve, and nobody wanted to. It was the most inexpensive intervention I've ever seen. So we just need to get some of that data out there, use that competitiveness to our advantage. And then to the burning platform point, I would be remiss if I didn't mention COVID. The things I personally saw with my own eyes during COVID in terms of how fast we moved on innovation in lots of different ways were astounding. I mean, let's just look around the room. Pretty much we all learned how to self-swab and send in tests. We've trained the whole population on remote and virtual screening. And one of my frustrations is that we haven't pushed that farther faster after COVID. There was a program set out by NHS Digital called GPIT Futures, where they procured a panel of video interfaces to do virtual consultations for primary care. This is many years before COVID. GPs didn't take it up. I think the uptake was 30 or 40%. And then, finally in COVID, we got into the high 90s. And that's come back a bit, which I think is right. But, that's a great innovation. Obviously, I don't need to mention the innovations that we had in terms of drug development during COVID. So, learning from some of those burning platforms. So getting away from challenges, and I think getting onto some good news. I was thinking about how do we make innovation adoption successful? And I thought I would take some examples of where we've already been successful here in the UK. So one is NHS 111. This didn't always exist. We might not remember that it didn't always exist, but it didn't always exist. And I think one of the reasons why NHS 111 has been such a success is because it wasn't introduced as an instead. It was introduced as an and. So it wasn't threatening. And I think if there was one theme of my thoughts from today, it would be, don't be threatening, be helpful. It was an extra thing. It was a way for people to access services when they didn't know what to do or they couldn't access services in another way. Same thing with IAPT. We have a huge challenge still with mental health services, and IAPT was introduced as additionality to the core service. The other thing that I thought was really interesting and that I love is something about audacious goals. So like Hep C, the government has set out to eradicate hepatitis C. And I think this is fabulous because it's completely doable. And in the years since 2015, there's been a reduction in mortality in Hep C in this country of 51%. And I completely believe that we can eradicate this disease. And the way that NHS England has gone about this, and this will be a theme that you've already heard this morning, is through a huge partnership with the pharma companies that manufacture the treatments for this disease, with prisons, with local authorities who deal with homeless populations. It's taking a big problem and breaking it down into the smaller problem of the populations who tend to get infected with this disease, and created a holistic program around it. So, these are, great successes. And then the other area where I think there's been great successes is just the broader institutional interventions that we've seen in this country that I don't think we really celebrate enough. Tony Young's Clinical Entrepreneur Program is awesome. And it's not just the support that these entrepreneurs get, not just the funding that they get, but it's that they go back out into the NHS and they're enthused and they're confident and they're building something, and that spreads, to their colleagues and to their organizations. The NHS Accelerated Access Collaborative is an amazing piece of work by NHS Digital, which brings government, pharma, life sciences companies, industry together with patients. It helps break down barriers, take decisions, implement things. There's obviously funding attached. The Small Business Research Initiative gives grants for innovation in the NHS. And then finally, I really think that pharma and the life sciences innovation pathway is a really good model for what I would call more core healthcare innovation. We figured out a way with NICE and with different funding pathways to bring innovative drugs to market. And I think that for core healthcare innovations, we should be following a similar path. Now, I just wanted to close by being a little futuristic. Again, if you go to my LinkedIn and see the blog that I did not write, but that I think is great, that I posted yesterday, it has a link to a report that we just published, which is our Predictions 2030 report. And in it, we have 10 predictions. And I think this is kind of a fun stimulus for the conversation that we might have next. So the first prediction is, and I won't talk about all 10 at length, I'll give you like 2 sentences, and I'll close here. But the first one is, consumers are the CEO of their own health. This one makes me laugh because obviously when I moved here 20 years ago, I thought I was the CEO of my own health. But that's really not the way that people consume services in the NHS. But that, I do believe, is changing. And then linked to that, I think we will see the rise of a really dynamic consumer health market. And I do think that this is generational, and we're seeing the younger generation consume healthcare services in a really different way to the older generation, but I think they also influence the older generation, so I think it won't be a full generation before we see that dynamism. The next one is really intelligent healthcare and the democratization of health data. Now, the democratization of health data has always been a really contentious point in this country, but there's no denying the fact that the data that is held in programs that have already been mentioned by colleagues this morning is incredibly valuable for research purposes. And I personally have always believed that not using it for those purposes is criminal. And I think that there's many other ways to democratize healthcare. And those of us who will be either working in the NHS in systems that have maybe Epic, or patients of systems that have Epic, you'll have MyChart. There's the democratization of healthcare data to us as patients and citizens, which is very useful. And I think that really changes the game when you begin to see and understand and hold your own data and know what's in it and be able to ask questions about it. Climate is something that I've been talking to our healthcare clients about for a long time. Healthcare holds a really interesting place in the climate conversation because healthcare is one of the least climate-friendly industries and is very greenhouse gas emitting, but it's also affected incredibly by climate. So, climate resilience and sustainable healthcare systems is incredibly, incredibly important. And there's a lot of work going on, and there's actually, this is going to be a big topic at COP coming up in Azerbaijan as well. So that's a big one. Convergence of AI technologies and human expertise in pharma R&D. We have already seen the speeding of the pharma R&D pathway incredibly through use of AI technologies, and we actually just recently purchased a company that does some of this, and it is so cool to see how quickly they can sort through millions and millions of possible options and pick out the potential winners. So I just think that's something that we're going to be so excited and impressed with, and that will be a huge leap forward in terms of the types of treatments that we can get to market and quickly. Interdependent innovations in science and tech. I loved how Ian started off the morning saying that, I don't know, decades ago when he trained, it looked much the same as it did today in terms of you have the outpatient, you have the referral, you sit and you wait. I really do think, and I think the digital pharmacy example is a great one. Like, we're going to redesign, we're not just going to digitize the current process and pathway. We're going to redesign the way the whole thing works. And I think that is the moment that we will really feel that healthcare is innovating and changing, the way that we've seen in the other sectors of our life. Our financial services interactions, our entertainment interactions. I do believe healthcare will get there. MedTech innovation and the Internet of Medical Things, we're already creating tons and tons of data that is not flowing back into a healthcare conversation. I've seen many Oura rings in the room today, Fitbits, et cetera. Our clinicians don't have access to this. There's all kinds of other data that's being collected. And in the worlds of the compute power that we're generating right now, we can assimilate all these things and create a more holistic picture for our own health. M&A, divestitures, and restructuring. So I was very heartened to see, in a funny way, all of the banks making so much money in their recent earnings statement, because I think this is kind of the harbinger for what's going to come for the part of the economy that we care about, which is healthcare. And I think that a healthy M&A environment is really important, and I think that the interplay between the public sector and the private sector in healthcare is a very important facet for innovation. And then finally, the convergence, health, wealth, and longevity. This is a huge, huge business, and consumers are thinking so much about healthy life years. And I think this will be another driver of innovation in healthcare as people begin to realize that the power of having a healthy, long life is in their own hands. And finally, digital and technological transformation of pharma. A lot of people have talked about this already, but I think the very expensive personalized medicine immunotherapies that we know are very successful today, those prices will come down, and that will change the way we seek and receive treatment. Thank you.
Thank you very much.
The Harley Street Health District, the home of healthcare since 1860.